I said, let me just place the region of interest somewhere else, a little bit off to the side, and let's see if I can get the fibers that I want. And I did that, and then I looked at the results like, oh, that looks like the trigeminal nerve. And sure enough, the whole field of diffusion tensor imaging in trigeminal neuralgia really developed out of that. So then these two circles just fed each other. The more patients I looked after, the more I became involved in research in trigeminal neuralgia and imaging of trigeminal neuralgia. And that now has really overtaken a sizable chunk of my practice. And as of a year ago, I completed 1,000 procedures for trigeminal neuralgia.
Welcome to Stimulating Brains.
Hello and welcome back to Stimulating Brains, episode number 8 already. This episode is special because it is a guest episode hosted by Luka Milosevic in Toronto. Luka is an assistant professor at the University of Toronto Institute of Biomedical Engineering, has done stellar work on neural recordings in the basal ganglia within the context of deep brain stimulation surgery over the last few years. And Luka has just moved back to Toronto from Tübingen in Germany to found his own lab, and I'm sure he's gonna put out stellar work there. And today Luka is interviewing Professor Mojgan Hodaie, who is a worldwide expert on brain stimulation for neuropathic pain. Luka will formally introduce Dr. Hodaie more properly in the following, but I'm really excited about this episode, talking about neuropathic pain, the application of diffusion tensor imaging-based tractography to treat trigeminal neuralgia, connectivity-aided targeting, neuromodulation for pain in general, and then the very exciting cases that they talk about. Dr. Hodaie has also been involved a lot in teaching, including a worldwide spanning neuron project that you can find under neuronproject.org, which is a Moodle-based teaching program, and I think a wonderful initiative to spread teaching in the field of neurosurgery across the globe. So I'm sure you're gonna have fun listening to this exciting conversation between Drs. Milosevic and Hodaie.
My great pleasure to introduce Dr. Mojgan Hodaie. Dr. Hodaie is a staff neurosurgeon at the Toronto Western Hospital with subspecialty training in stereotactic functional neurosurgery. She's the surgical co-director of the Gamma Knife Center at the Toronto Western Hospital, and she has expertise in all forms of neuromodulation, including deep brain stimulation, spinal cord stimulation, baclofen pumps, and I'm sure I'm missing some other indications. Her primary research focus these days is on structural MRI imaging and functional neurosurgery with a special focus on neuropathic pain. Dr. Hodaie is also a full professor in the Department of Surgery at the University of Toronto and has contributed immensely to teaching neurosurgery and neuroanatomy not only here in Toronto but on a global scale. Dr. Hodaie, I've had the privilege of working with you in your DBS surgical theaters over the years. And I can easily say that you're responsible for at least 80% of what I know about human neuroanatomy from my days as a student in your class. But I've also come to realize that the ways that our lives have overlapped over the years is probably just a small fraction of what you do on a day-to-day basis. So I'm very much looking forward to learning more about you and your accomplished career.
Luka, it's a pleasure to speak with you, and I think it's a great opportunity for us to just sit down and have a chat.
Yep. So, Dr. Hodaie, can you walk myself and some of the listeners of this podcast through, as much as you feel comfortable sharing, basically some notable life events that led you to the moment where you first thought to yourself, I want to become a neurosurgeon?
Sure. Luka, I have to start by saying that this is probably one of the toughest questions that I get asked, and I have never found a very good answer for it. And I suppose that's probably because, the way we make decisions is based on so many factors, and, there's fluidity to it. So sometimes I think one factor is more important than another. But regardless, I mean, I was born in Iran. And I left that country as a child. I grew up in Spain. And, there's not really too many doctors in my family, just one of my sisters and myself. And this was not a path that I envisioned for myself as a child, as a young adult. I was always attracted to science, there was no doubt of that. And I was attracted to medicine as well. And one of my great passions has always been organic chemistry, of all things. A life in neurosurgery was not really what I had thought of. I mean, we can go and analyze that, and perhaps some of it is the opportunities that were available, particularly to women. Mm-hmm. Nonetheless, what really drew me to that field was my father, because he had hemifacial spasm. So upon searching for solutions for him, I met who ended up being eventually my father's neurosurgeon, even though he actually never elected to have surgery for it. And then I became connected with Dr. Andrew Talala, who was a neurosurgeon that we saw, and he was an amazing man, and he truly became my mentor. Mm-hmm. At the time, I had already started some interest in neuroscience, and then just that rose exponentially. And I had the opportunity to attend clinics and really become immersed in the life of a neurosurgeon. Dr. Talal at the time was effectively retiring, so he had cut down his surgeries and so on. And he really was, I think, that the opportunity of him being involved in a different type of teaching of someone who I wasn't even in medical school at the time was something that was appealing to him, and he was an amazing teacher. So I think that totally revamped my life. And as I went into medical school, as much as I truly enjoyed medical school, every aspect of it, there was something very special about the brain, about the neurosciences, about neurosurgery. So that's really, I think, a major factor, even though not the only one. Mm-hmm. I think altogether, the life of neurosurgery with respect to the intensity of it, the aspects of how much we're able to intervene and change someone who effectively everybody else almost gives up on, mm-hmm. and we bring them back to health. And the fact that we take a very complex problem and we dissect it into smaller, simpler bits and connect all the dots to come up with a solution. I found those incredibly interesting.
Mm-hmm. Where did you meet Dr. Talala? Was that in Spain or?
No, he was, we were living at the time just outside of Toronto, about an hour and a bit. And Dr. Talala was working at McMaster, where I was as well for my undergraduate. So that's where I met him. And he's now passed away, but I remained connected with him really until the very end. So he's been a huge influence in my career, and his picture is up on my wall. He's, of course, he's not the only mentor that I've had. It started there. And I think as much as education is important, I think the role of mentors is also very crucial. And how they allow you not so much to learn differently, but shape your learning. And how they allow you to drive that sense of curiosity that every learner has, the way you think about problems, the way you deal with problems when, you're not having a good day or something doesn't make sense. And the way you structure your thought as you approach your career and your patients and so on is I find that incredibly important.
Mm-hmm. So I guess once this seed was planted in your mind that this is something you wanted to do as a career, where did you go from there? I think you mentioned that you did your undergraduate studies at McMaster University, which is in Hamilton. It's about a 45-minute drive outside of Toronto. What led you from the moment where you knew this is what you wanted to do, mm-hmm. to the position that you have here in Toronto today?
Yeah, so I did my medical school at Queen's, which is about 2 hours away, and then I came to Toronto for my residency training. Mm-hmm. Residency training in neurosurgery, particularly in Toronto, particularly the time that I did it, although it continues, is fairly rigorous. Mm-hmm. And obviously, you have to get accustomed, but in looking after patients that have all sorts of disorders. So I generally say that there's quite a lot of persistence required, persistence to get into neurosurgery, and persistence to remind yourself that you should stay in neurosurgery, because it can get pretty hairy and intense. Nonetheless, this is what we do, and this is what we love to do day in, day out. So from there, obviously, the years of general training of neurosurgery were there, and then in the middle of that, I took some time to do research in functional neurosurgery, and I did that with Andres Lozano, working on deep brain stimulation for epilepsy.
Okay.
And
this is before your fellowship here.
This is before my fellowship. So I did an enfolded, essentially, research fellowship within my residency. And then at the end of my fellowship, I did 6 months of surgical fellowship in functional neurosurgery here. I should say that I did my residency at a key time, and that was the very, very end of Dr. Tasker's clinical and surgical time. So I had a very short but very valuable window of working with him. And I have to say, I clearly remember when, I believe it was the year 2000, when we had one of our professorships, and Dr. Tasker was, even though he was from Toronto, he was our visiting professor, in honor of him essentially leaving his surgical practice. And as you know, he had done a tremendous amount of advances in our understanding of the thalamus and working with chronic pain patients. And he's published one of the most singular books that I have a copy of in my library, called The Thalamus and Midbrain of Man, where there is over 5,000 recordings of the human thalamus and findings in the motor and sensory parts of the thalamus and so on. And the question that I had for Ron Tasker is, when did he feel that we would come to an objective understanding of pain? And as he was answering that question, somehow between his question and my mind, things sort of flew off, and that level of curiosity, I think, has still stayed with me, and it has shaped quite a lot of my research career. I must note as well the great influence of Jonathan Dostrovsky, who is essentially the father of the physiology that we do here, and of course Karen Davis. So all of these are key figures that shaped the later part of my clinical and research training, as well as my research career.
That's excellent. So you're probably a very excellent resource to ask about sort of the history of stereotactic functional neurosurgery in Toronto. I think many of the people who have been on Andy's podcast have been from Europe, but I think everybody knows in some way or another that Toronto is a very special place and holds a very special place in history in stereotactic functional neurosurgery. So you just mentioned some of the key figures, Dr. Tasker, Dostrovsky, Karen Davis, of course Dr. Lozano. Do you want to expand a little bit about, sort of give people a background about the history, the rich history that we have here, and at what point in that timeline did you acquire your staff position, and sort of what was the state of the art at the time of you acquiring a position?
So the formal aspect of stereotactic functional neurosurgery really starts with Ron Tasker here in Toronto. And I should say that Toronto is the oldest neurosurgical program in the country, dating back to 1923. So when Ron Tasker started as a staff neurosurgeon and took on these very challenging cases that really other neurosurgeons did not look after, he really took it on with a perfectly matched hat of surgeon and scientist. So every case was also a research opportunity for him. And that is a legacy that we've continued as well, as you know. I remember when I was in my first year of residency and I walked into the OR, I frankly can't remember what case he was doing. I know that Andres Lozano was there as well, and what I really did feel that I was living part of history. And I should say that as a medical student, I did an elective elsewhere outside of Toronto, and the functional neurosurgeon there was doing a procedure approaching the thalamus, and he called for the Tasker kit. So when he did that, I realized, I see. So now I know where this is, where this is coming from.
Yeah.
So the guy that actually put that kit together is, in Toronto. So that was very meaningful to me. Obviously, it spoke of the impact that Tasker had in many other institutions as well when, they use his kit to perform the procedures.
What would be in that kit?
So typically a lesioning electrode, a 2 millimeter tip lesioning electrode, and all the bells and whistles that go with it. But that was at the Tasker kit.
Yeah.
It's maybe a little sideways thing to say that I have been very impressed by how much serendipity influences one's life.
Mm-hmm.
And as much as, people used to tell me that in terms of research and so on, that serendipity has so much, it's like, yeah, I wouldn't believe them. Like, yeah, sure. I mean, but now that I look at my own life, I realize so much of what has happened to me has happened in a serendipitous manner. And it's really valuable for us to sort of keep, at least I try to keep my eyes open, because serendipity just means, that you observe things at the right time, frankly.
Yeah.
And as it happens, in fact, one of the interesting things in the field of functional neurosurgery were the developments by Cooper, Irving Cooper, the neurosurgeon from New York, who developed the sort of cryothalamotomies. And Dr. Talala was actually very interested in those procedures, and he performed quite a few functional procedures. Somehow I've been able to, circle myself around this field, and eventually, I guess, meet myself at the very beginning again. But yeah, I mean, the influence of Ron Tasker and, of course, Andres Lozano, who came as Tasker was wrapping up, and Johnson Dostrovsky, Bill Hutchinson, Karen Davis, and this key collection of individuals who are each thinkers and scientists, and really go well beyond the isolated transactional approach of a patient has a problem, I'm going to do this to fix them, to thinking, why does a patient have a problem? And how can I understand this so that I can treat the patient better, I can understand the brain better, I can understand the circuitry and the connections in a different light. And that has been such a huge motivating force for all of us working here in this field. And in terms of where we started, there's a fantastic paper published by Ron Tasker in which he describes the many decades that he spent doing this work and what the lay of the land has been and what he developed. But from then till now, there have been so many advances in treatment of disease, neuromodulation, looking at many different targets, understanding of the brain circuitry, developments in the hardware that we use for neuromodulation, and then many other things. So for instance, when I was doing my fellowship, effectively, we were primarily doing deep brain stimulation, very few other procedures. Now when our fellows come, they really have the depth and breadth of functional neurosurgery at their hands. So the heavy amount of neuromodulation of all kinds, brain, spinal cord, peripheral field stimulation, and so on. A huge practice in trigeminal neuralgia that I've developed, gamma knife radiosurgery, focused ultrasound, laser interstitial therapy, and this doesn't even approach the many aspects that we have for either resection or stimulation of patients with epilepsy. So the field is very, very broad, and I think all functional neurosurgeons recognize that the field is not defined by neuromodulation alone. It's much bigger than that. And we have to do it justice, obviously, because it's a pervasive problem within our society, whether you look at pain, at movement disorders, at psychiatric surgery. And we need to come up with good approaches to help our patients.
Yeah, of course. So in terms of your own sort of career trajectory, when you came in here for your fellowship, you mentioned it was heavy on the DBS side, probably lots of movement disorder cases. You mentioned the epilepsy cases that were being done at the time. Do you want to just chat a little bit about sort of how maybe the rise and fall of certain indications in DBS? What was sort of the state of the art at the time, specifically related to DBS? I know you have a subspecialty, of course, in neuropathic pain, and we'll certainly talk about that. But just in terms of DBS, I know there was a lot of cases for pain here. There was epilepsy cases, and where are we today, and sort of what's been the evolution in these sort of indications that aren't as conventional these days?
Yeah, so some conventional indications have remained. For instance, the specific indications of GPI DBS or even thalamic DBS for essential tremor, for instance. But as experience has increased in some other areas, we have seen a rise and fall in certain things. Certainly, there's been the initial rise of STN DBS that has definitely persisted. Mm-hmm. Other targets, for instance, the pedunculopontine nucleus has sort of frizzled a little bit. Huge interest initially in motor cortex stimulation, that although perhaps it remains in some parts of the world, and I know it's not DBS, but still part of the conversation, I suppose, although it remains in some parts of the world, I have been really not very impressed with the results we have, chiefly because I think we do not have the correct hardware to stimulate the motor cortex. We use, electrodes that are meant for the spinal cord, and mm-hmm. we think that putting it on the motor cortex would work the same way. I don't think it does. Mm-hmm. And yes, pain is a big field. The more procedures we have done in the field of deep brain stimulation for pain, the more we've realized that its long-term outcome is tenuous at best and quite unpredictable. So again, we need to understand the science of it a lot better before we are able to offer solutions for predictable solutions, at least that we can rely on and give good prognosis to patients.
Yeah. You were mentioning to me earlier that you're doing more and more trigeminal neurology cases. When did that begin? I'm privy to your operating schedule, so I know that you do microvascular decompression surgeries, gamma knife, radiofrequency rhizotomy. What's the timeline of all these different therapies? How do you match a particular therapy with a particular patient? How do you make that? What's the decision process here in terms of one trigeminal neurology patient, and then this plethora of techniques you can use to treat them?
So when I first started as staff at the Toronto Western in 2004, obviously my subspecialty has been from the get-go in the field of functional neurosurgery, and there were perhaps a few referrals of patients that had trigeminal neuralgia. In 2005, so very shortly thereafter, we started with our gamma knife program, which attracted, of course, a good number of patients with trigeminal neuralgia for treatment. So out of the interest in that field and to be able to help as many patients as possible, I became involved in gamma knife radiosurgery, and then slowly the patients grew. I should say that around that time, I became very interested in exploring the advanced imaging techniques such as diffusion tensor imaging. My initial goal was to study the fibers of the brainstem, as they would help us with better targeting in deep brain stimulation. and I'll go back to serendipity again because I was actually preparing a talk, and I was trying to figure out, how can I just find a nice view of these crossing fibers and explore those with DTI for this talk. And I tried, and it just wasn't coming to me. And I said, maybe it's a technical issue with this specific software drawing these, taking DTI information. And I said, let me just place the region of interest somewhere else, a little bit off to the side, and let's see if I can get the fibers that I want. And I did that. And then I looked at the results like, oh, that looks like the trigeminal nerve. And sure enough, the whole field of diffusion tensor imaging in trigeminal neuralgia really developed out of that. So then these two circles just fed each other. The more patients I looked after, the more I became involved in research in trigeminal neuralgia and imaging of trigeminal neuralgia. And that now has really overtaken a sizable chunk of my practice. And as of December of 2019, so a year ago, I completed 1,000 procedures for trigeminal neuralgia with, very large and also very interesting research in this area. So again, sometimes things just happen. You have to be ready for the opportunity and be curious enough to pursue those leads that life gives you.
Mm-hmm. So how do you, going back to the question of the various techniques that you have to offer, how do you decide which patient gets which type of procedure?
Yeah, so we rely on obviously the type of symptoms that they present, their age and medical status, and whether they've had prior procedures before. If they are reasonably healthy and they have not had a prior procedure before, microvascular decompression still remains the best treatment that we have to offer based on the likelihood of them being pain-free after the procedure.
Mm-hmm.
Having said that, there's a sizable number of patients who are younger, they're quite healthy, but they also have busy lives. They might have young children, their own business, etc., and they don't really care for the downtime of a surgical procedure, and therefore in those patients, gamma knife radiosurgery is becoming a very popular route as well. So I would say that these two procedures, microvascular decompression and gamma knife, are fairly high up in both numbers and options that patients seek. I typically use rhizotomies, whether they're radiofrequency or glycerol or whatever type, as second-line procedures. They tend to be more injurious to the nerve, and I always have a hesitation of possibly them resulting in the afferentation type pain. Also, patients are not quite so keen having dense numbness of the face. So obviously, if it can be avoided, that's preferable. So I keep those as second line. And then beyond that, I see a sizable number of patients that have had multiple recurrences, or they might have, for instance, multiple sclerosis, which really typically takes them away from the option of microvascular decompression. And we explore a number of peripheral procedures in those patients. Atypical trigeminal neuralgia is not uncommon at all, and again, in those patients, I really favor the possibility of neuromodulation, particularly peripheral field stimulation. After having seen so many patients, we recently actually were able to identify a very unique syndrome, a syndrome that is depicted by a very unusual type of a single lesion within the pons, which is just within the brainstem fibers of the trigeminal nerve. This is important because these patients effectively, they're non-responders to surgical treatment, conventional surgical treatment. And by that I mean, we see them oftentimes, they've had many procedures. They've either come to me or they've come referred to me from other neurosurgeons. And routinely, these patients, they might have a good response, but it lasts very short duration of time, and then their pain comes back. So in those patients, I've been much more keen in moving to neuromodulation right away, and not put them through the risk of conventional surgery.
What's the sort of long-term efficacy of the neuromodulatory approach?
So it's a procedure that we've just started a few years ago. I don't have a very a long experience with these in terms of how they last. I do have a patient who had, this was my first patient that had a peripheral field stimulator put in, I would say nearly 10 years ago. She had very bad postherpetic neuralgia. She wasn't completely asensate in the face. She had some sensation, so therefore we tried this. And even though she still has some pain, the pain is at least manageable for her. So that is the longest effect that I've had so far. But of course, we know that neuromodulation provides the advantage of fine-tuning the stimulator and allowing us to be versatile with how we treat patients. So as patients explore this journey of having a stimulator and managing their face, we learn more and more, and we hope to also research this in different areas so that we have a better understanding of the networks that are involved and how we might be able to, before surgery, have some level of accurate prediction of what the likelihood of response might be.
Great. I wanted to ask you, because you mentioned some sort of, let's say, special indications for pain. Are there any particularly memorable individual cases that stick out to you, whether it be deep brain stimulation cases or trigeminal neuralgia cases, or maybe one of each that stick out in your memory, where perhaps you learned something from the procedure itself or from that patient?
Yeah, there's many, Luka. I think, we need to learn from every single patient that we see, whether we operate on them or not. And I think we are uniquely blessed in that way to have that opportunity to contact patients and understand what they're going through. So memorable moments could refer to potentially, issues that pertain to the experience of the patient, and there have been many, and also issues that pertain to the science that is related to that specific case. There's no doubt the richness of thalamic surgery is incredible. So particularly sensory thalamus, when we get right deep into VC as we do VIM surgery, and we see that we detect cells that are responsive to one type of sensation, and some. I mean, it's just fascinating. It's such beautiful electrophysiology. The observation is something that we take in. We see enough of it, so potentially we get used to it. But to be able to arrest a patient's tremor and to appreciate the impact that this has on their life is quite a sight to behold, and we should not take that for granted. Perhaps one of the most interesting cases I've done, and we published this a few years ago, was a patient that saw me for intractable hiccups.
Okay.
And she had been hiccuping continuously, several times a minute for the past time when she saw me, maybe upwards of 4 years. And she was totally at her wit's end, understandably so. I mean, spending a bit of time with that patient in clinic was, for us, exhausting because we could appreciate the patient's discomfort.
Yeah.
So through a set of investigations, which included EMGs of her diaphragm bilaterally, as well as a block of her vagus nerve under ultrasound in the operating room, which involved anesthesia, putting a needle in her carotid sheath in between the carotid artery and the jugular vein. We gave her a Horner syndrome for 48 hours, and we got rid of her hiccups completely for those 48 hours.
Wow.
So knowing that this works, we put in a left vagal nerve stimulator, which she's had for, I think we put it in 2009, so we're coming to almost 11 years. And she is a ton better. She remains well. She still has hiccups, but to a much, much lower frequency. They're totally manageable, and I get a call for her every few years when the battery needs replacing, and then her hiccups are bad. And then we go back all the way to square one. So, I mean, these are obviously very unique cases, which come once in a while. But honestly, I think it's a matter of really trying to understand and appreciate every bit of science and every bit of clinical interaction that we have with patients. It really is a blessing.
I appreciate that you mentioned the important role of electrophysiology in stereotactic functional surgery. Of course, personally, of course, your research work with DTI has also impacted upon how you perform your cases. So I think one sort of semi-controversial thing in the field nowadays is to do asleep versus awake surgeries. I know that you're partial to awake surgery because I'm fortunate enough to be in the OR. But can you speak about sort of the implications of how research impacts upon clinical practice, for example, and how you've personally seen things sort of come to fruition from in that order, research-driven advancements to neurosurgical procedures?
Well, in my view, the key advances in science and medicine have been driven by research. I don't think anyone can argue that. Now, does that mean that everyone should do it that way? I think that depends on, the site and the individual and the conditions, the clinical conditions that allow for such a thing. And if we all could do it, that would be wonderful. But I do acknowledge that this is not possible everywhere. Having said that, certainly those who have a setup that allows for research to be integrated in surgical practice, we really need to take as much advantage of that as possible for the sake of the science and all the information that will come out of it. I'll also acknowledge that time has allowed me to understand that things can be done well in different ways. And therefore, there have been instances in which, by way of, I would say, our routine practice, we have done, or we've tried to do DBS in a patient that's awake, and it really hasn't worked. The patient is uncomfortable, they're not cooperative. And, in certain cases, we have to take that into account and do the surgery while they're asleep. And the wealth of the understanding and experience that we draw from our field really helps us in those cases as well. In other places, things are done a bit differently. And this is an eternal conversation, awake versus asleep, electrophysiology versus no electrophysiology. And there's been heated debates about this, some of which I have been moderating, and some of which I've been in the audience, and some of which have been a little bit too controversial. Nonetheless, honestly, I think things are, can be done well in different ways. They just need to be studied, and they need to be done for the sake of the best care for the patient, and not just as a routine, because that's the way we do things.
Yeah, absolutely. I want to touch on sort of your involvement in teaching. But before I go there, I just want to rewind all the way to almost the beginning of our conversation, where you mentioned opportunities for women in neurosurgery, and actually the way in which this interview between myself and you today sparked was because Andy tweeted about looking for, he mentioned that why is it so difficult to find a female neurosurgeon to interview for this podcast? And he asked for recommendations, and of course, immediately I thought of you. And you mentioned as well opportunities available to women at the time in neurosurgery. Just a very quick Google search, I found a statistic that's frightening, that Canada has approximately 333 practicing neurosurgeons, only 36 of whom are women. That's 11%, and of course you're one of them here. We know that the chair of neurosurgery for the University of Toronto is a colleague of yours and mine, Luka Milosevic. So that's wonderful. But of course, seeing these things on Twitter and whatnot does not reflect these statistics. So what are some of these challenges that prevent women from engaging in this career? How can we improve this rather scary number?
Yeah, well, I could talk about this for a while. We've persistently been one of the surgical specialties where representation of women is the lowest, if not the specialty where it is the lowest. So we've been riding about 10% for a very, very long time. I think there are several aspects. It is obviously, I'm not going to whitewash it, it's a very intense specialty. And in its intensity, both physically, emotionally, intellectually, in every aspect, I think a number of people, men and women, decide that, maybe I'll do something that's a bit more life-friendly. I struggled with this for a very long time as to, why is it that if anybody, myself or anyone else, wants to do neurosurgery, we have to go through so much? I don't know that I have a very good answer to it. Short of saying that, the tool that we have to play with, which is the brain, comes with a responsibility and a consequence. And I don't think that we can minimize that. I think with respect to women, though, I have to say when I was expressing my interest in neurosurgery and in medical school, out of very good intentions, essentially everyone that I spoke with tried to change my mind.
Okay.
At a rate of maybe 1,000 to 1. There were only literally 2, maybe 2.5 people that said, if you really want it, go for it, and that, they backed me up. One of them was of course Dr. Thalala. One of them was a very dear friend to me, who was an ophthalmologist, Dr. David Smith, that I spoke with, and they both encouraged me to do this. And I chose to listen to the two of them. I could have listened to the other 1,000. Nothing that the 1,000 people told me was incorrect. And in fact, they were very correct and more, because when you start residency, you realize, holy smokes, this is not, this is intense. But now, in retrospect, I wonder whether they tried to turn many men away from the specialty as well. I don't know. I wasn't in those shoes to say.
Yeah.
So there are many, many factors, right? And there are factors that are individual, there are factors that are societal, how we project as a specialty, how we project ourselves in medical schools, and whether we project ourselves as a field that only very few can come to, and so on, and a bit of a very special attitude, or whether we project it as this amazing opportunity that you have of integrating science and surgical skills to really drive our understanding in this area. So yeah, it's I think at the end we'll have to take a multifaceted approach to allow for change. Within this 11% that you mentioned, or altogether within neurosurgery, to have a career that involves surgical treatment of these conditions as well as science is even a smaller number. But I think beyond that, at some point in time, then perhaps numbers only mean so much. And again, you have to have enough persistence to just push through and open the doors for those coming after you.
Yeah, absolutely. So let me ask you another then difficult question. You mentioned the two people who supported you and who really pushed you to do this, and the 1,000 others who maybe told you to reconsider. But if a young woman, let's say, walked into your office and said that you're a role model for them, and you had to give some advice for them, would you be part of that 1,000? Would you be part of those 2? And what advice would you give that person?
Well, I think whatever words come out of my mouth, they need to be perceived in context of the person that's listening to them. The same way that I listened to those 1,000 and I chose to ignore it. I think I would try to project a balanced view and really do explain the details of a life in neurosurgery. But I hope that no one gets dissuaded by the intensity of the specialty. We're not the only intense type of work in society. There is many other aspects of either medicine or other specialties that are very, very intense. And I don't think that we should shy away from anything. If you want to do it, if you think that you're qualified for it, and if you want to dedicate yourself, not to a job, but to a career, then do what you think is the right thing to do for you.
Right. Wonderful. Let's segue to, speaking of giving advice, and let's segue sort of towards mentorship and teaching. What sparked your, actually first let me recap sort of your involvement. Maybe you can fill in some of the holes. As far as I'm aware, you're still giving a course, Advanced Neuroanatomy, in the Institute of Medical Sciences at the University of Toronto. Do you do any teaching locally besides that?
Yeah, so I've taught that course, Advanced Neuroanatomy, of which you were one of the star students, Luka, since I believe, if I go back, 2009. There's a pause now for 2021, given pandemic and so on. So yeah, that's been one area of involvement. Obviously, my graduate students and so on have been a huge source of my educational involvement, and I'm extremely proud of them. And I'm currently the site director for our neurosurgery residency program at the Western, and on the education leadership committee. Looks like we work in a hospital, huh?
Sounds like it, yeah.
So I have a number of educational hats, I suppose, which are involved, and they're absolutely amazing.
There's also, besides sort of the local involvement you have at the University of Toronto and here at the hospital, I was reading a little bit about the Neuron Project. So you're the founder of the Neuron Project, which stands for the Neurosurgical Education with Universal Reach. Can you tell me more about this program? Sort of what is your involvement in it? What is it? How do people gain access to it?
Yeah, so I developed this in the context of my other passion, which is global neurosurgery, and the fact that if we look at the world as one entity, which I truly believe that it is, and it is one of my own core beliefs, then why is it that in some places, such as here, we are so comfortable with the health care that we have, and in some places it is such a struggle? And if we think about it in those terms, in fact, we see that the burden of neurosurgical cases in places such as low-income countries is huge when you look at trauma. The sheer density of cars in the population, the poor, at times poor social infrastructure that results in motor vehicle accidents and so on. All of them really hit the young in society. And the programs need to be obviously very, very strong to deal with that, and oftentimes they're not. So as part of the opportunity that I've had to travel to different programs in different hospitals and so on, I developed this entity called the Neuron Project, which effectively tries to provide a structured online curriculum, didactic curriculum for surgical training. So typically we think of surgery as being one that involves, excellent surgical skills, technical skills. What typically others are not aware of so much that are not surgeons is that a ton goes into surgical decision making. And of course the knowledge base that you need to have to be a good surgeon. So it's that aspect, the surgical decision making and all the knowledge required, anatomy, surgical anatomy, neuroradiology, neuropathology, and so on, that really needs intensifying and fortifying for many of these low-income countries because they just don't have the right setup. They're excellent surgeons. They learn to operate really well under their own circumstances, but that part, if it becomes intensified and structured, then their learning will become so much more effective. And, it's a way of effectively strengthening their programs without them having to leave the country.
Mm-hmm.
So this program has been tried and deployed in different places, including Cambodia, including Vietnam. There were a number of courses that I had initially in Africa, in Ghana. And through a series of circumstances the past year, it's flattened a little bit, but it will resurface very strongly in the year to come. And there have been, of course, key partners to this, surgeons worldwide that are interested in global neurosurgery that I've worked with them in the US, in Japan, in different places. And we form an amazing crew that really is interested in driving and strengthening residency programs throughout the world.
That's exciting. Perhaps this is a good plug for the program then, and if there are any interested listeners,
For
maybe
sure.
they should contact you about such an opportunity. So the last thing I wanna chat about. I've attended several sort of World Stereotactic Functional Neurosurgical conferences over the years. I know that you're always very involved. You're on the board. I think you're the treasurer, or
Yes, I was a treasurer, now
Okay.
the vice secretary.
okay, perfect. So what can you sort of define a role for these organized societies for the advancement of neuromodulation, DBS, stereotactic functional neurosurgery? Do you feel that this is sort of something that's very important to contributing to the field, and how does it impact
I think
the
so,
field?
Luca. I think it's actually very, very valuable to have a form of conversation and a form of for global conversation. It's a fantastic opportunity. First of all, it's a very historical society, as it developed initially for a society for the study of encephalography. And then it became the World Society for Stereotactic and Functional Neurosurgery. So it goes back to the times of Spiegel and Weisses that effectively started the field for us. But really, any opportunity that we have at a conversation, whether it's a face-to-face meeting at a conference, whether it's a webinar, whether it's a symposium online, it allows different thoughts and different styles of surgical approach to come together. And it all eventually distills into what we decide to do in terms of surgical approach and understanding of where the research is going. An incredible opportunity for young surgeons, residents, fellows, researchers to come and meet others and form partnerships, cooperations. So I think these societies have a very, very unique role and value. I've had the great fortune of chairing the scientific program for 2 of our meetings, and it's been absolutely fantastic. And then you also get to have friends all around the world, which is awesome.
Yeah, of course. All right, Dr. Hodaie, that was excellent opportunity to chat with you, learn a little bit more about yourself, your career. To appease Andy Horn, I'll leave you with one final question, which is, what is your favorite brain region and why?
My very favorite brain region is the insula.
The insula.
The insula is a very small and, as you know, hidden under the opercula of the brain. But boy, for a small region, it sure does quite a lot.
Mm-hmm.
And it's such a fascinating structure that, you read papers about all kinds of stuff, and the insula keeps popping in again and again. So it has consumed my curiosity for a very long time. And I must say I have been very interested. I've talked to a number of people about the opportunity of stimulating the insula for certain conditions. It's a difficult region to get to, and parking an electrode there has its own challenges as well. But I didn't have to think about that too hard.
Okay, wonderful. It's intriguing option for sure. Well, thank you again for your time. I think I have to run down to the OR, and I'm sure your schedule is keeping you busy as well. But it was a pleasure speaking with you, and I look forward to seeing the OR in the next few days, probably.
Thank you, Luka. Thanks for the opportunity, and it was a wonderful conversation.